Hi class, so this is your Ticket to Class Module 4 Immunity and Infection lecture. So this is what we would be doing in class, okay? But I'm not going to be there, so we're going to do it here. All right, so slide number 2. This is just some patho reminders for you. Bone marrow, thymus, and spleen are all imperative to the immune system, right? Bone marrow is where the B and T cells are made. So we have yellow bone marrow that's inactive, okay? It doesn't do anything. But red bone marrow is where our B and T cells are born. B cells stay there and mature. B cells are what become antibodies. T cells go on, they migrate to the thymus. I always remember T cells, T for thymus. So the T cells go to the thymus to mature, and they become things like suppressor T cells. Suppressor meaning that they hold things back, or helper T cells, or cytotoxic T cells. So all of these T cells are programmed to kill things, right? To basically like support the antibodies and kill things. Okay. So then we have the thymus. Thymus is important because that's where T cells go to mature. Without the thymus, our T cells would have nowhere to grow up and differentiate. And when we talk about differentiation related to cells, we mean that they go and turn into something more specific. Okay, so like our T cells become suppressor T cells, effector T cells, cytotoxic T cells, right? So those are T cells that have a more specific job to do. They differentiated, okay? So we also talk about the spleen. So the spleen is a blood filter, part of the lymphatic system, but part of the spleen has red pulp, okay, which is where the red blood cells and the blood gets stored. But then the white pulp is where macrophages and lymphocytes are. And those are some of our big old fat white blood cells, that go in and eat toxins and bacteria and all that sort of stuff. So if you have somebody who ends up with a splenectomy, so spleen removal, right? And when I was working at the hospital, we really saw this related to motorcycle accidents. And I don't know if it's the way people land, I don't know what the deal is, but a lot of times the spleen would be ruptured and they'd have to do a splenectomy on these guys. And if the spleen is removed, then you're immunocompromised for the rest of your life and have to be on antibiotics forever, because now not only do we no longer have that red blood cell reserve available, but there's no place for your macrophages and lymphocytes to hang out, and they're a huge part of the immune system. So we don't often talk really in depth about pathology, pathophys, but I guess physiology. But keep in mind that bone marrow, thymus, and spleen are very important to the immune system. So slide number 3, we talk about humoral mediated immunity versus cellular mediated immunity. When you hear humoral immunity, that is just fancy for antibodies. Okay, so this is our B cells, which go and turn into antibodies. Antibodies are specific to an antigen. An antigen is just anything that invades the body, anything, okay? Antibodies are created to fight the antigen, okay? So humoral mediated immunity, that's just fancy for antibodies, okay? B cells. Cellular mediated immunity, that's our T cells that we just talked about, okay? T lymphocytes. So type of white blood cell, T cells, they go in like cytotoxic T cells, killer T cells, you'll hear that too. They go in and just fight things, okay? They are not specific. They are just generalized to fight whatever, doesn't even matter. They don't care what they're fighting, they'll fight it. Whereas antibodies are specific to an antigen. Okay, so now slide 4, we have passive and active immunity. So passive, like the biggest example of passive is when babies are in the womb and get antibodies from the mom via the placenta. And then when babies are born, if a mom is breastfeeding, they continue to get antibodies through the breast milk. So the mom is just giving the baby antibodies. These antibodies are already made, they're already formed, the baby didn't have to do anything. You're just getting antibodies. And antibodies are going to go and help fight specific and general antigens. Okay. And again, an antigen is just some sort of invading something or other to the body. It can be bacteria, virus, what parasite, right? Whatever. Doesn't matter. Also, not babies. These days, we like to give people IV, IG. That means just IV, intravenous, immunoglobulin. Immunoglobulin is another name, yet another name for antibodies. Okay, so if I give you antibodies via an infusion, those antibodies are going to be ready to go, right? Your body didn't have to make them. They didn't have to mature. Those B cells didn't have to do anything. I'm just giving you pre-made antibodies, right? So the benefit of passive immunity is that it's effective immediately. The body doesn't have to do anything. I'm just like, here's some protectors, here's some antibodies, right? So your body doesn't have to do anything. So they are effective immediately. Now, active immunity, this means that the body had to work to make these antibodies. So there needs to be an antigen, the body has to recognize it. After the body recognizes it, it makes antibodies specific to the antigen. And this can take a few weeks, right? This can take like 3 to 4 weeks for that whole process to happen. So an example of active immunity is vaccines, because a vaccine, what it does is it gives us a little bit of dead whatever, enough for our body to respond to it. Doesn't make us sick, but enough for the body to respond, make some antibodies, okay, realize that it's an antigen, recognize it as an antigen, make the antibodies, right? And now we have immunity. So should we come into further contact with a similar antigen, then we already have antibodies made to it. Also, active immunity is if you actually get the antigen, right? So if you get COVID-19 or if you get RSV, your body's going to recognize it as an antigen. It's going to make antibodies towards it. We call this natural immunity, okay? Natural immunity means that you actually contracted the antigen. It wasn't in the form of a vaccine. Um, and natural active immunity is the strongest form of immunity. Okay, it lasts the longest. Your body ends up with the best antibodies, most effective antibodies related to natural active immunity. But remember, the thing with active is it takes a little bit, takes a few weeks, because the body has to recognize that there's an offender, it has to respond, it makes those antibodies, it takes a sec, okay? So passive immunity, effective immediately. Active immunity, active. The body is actively working for that immunity. Now, innate defense barriers, you're born this way. Innate, we just all have this, okay? All of us have skin, all of us have mucous membranes, all of us have protective lining of the organs, right? So these are physical and biochemical mechanisms that the body just comes with. If you get a body, you get these things that are set up to help us get rid of antigens. Okay. So, like, look at the second list, like sloughing, sneezing, vomiting, urination, diarrhea, and drainage. Okay. All of those things is fluid trying to flush the body of whatever, right? All of those things. And that's why, like, if you have C. diff or some other like bacterial gut infection, um, or virus or food poisoning, like, we don't want to give you antidiarrheals. We want you to poop it all out because that is your body's mechanism for ridding the body of the pathogen, right? I don't want to stop you from having diarrhea because that's how your body's getting that thing out of there, right? Sneezing, vomiting, sloughing, all of that stuff is just your body trying to rid itself of those pathogens. Here's just a little picture of some of the cells and things like related to innate immunity versus adaptive immunity. Remember, adaptive, like here's our B cell, right? So that's our antibody. So we have B cells and we have antibodies, okay? So adaptive means it is going to change based on whatever the antigen is. Okay, so there it's going to adapt to whatever the offending thing is. It's gonna, what's the best way to fight it? It's gonna change, it's gonna be specific, and it's gonna be a little bit more effective too, right? Innate immunity, these things are the same no matter the offender. So whether it's a bacteria, a virus, a parasite, innate immunity is what it is. Okay. Adaptive immunity, antibodies are going to change. B cells are going to turn into antibodies that change. Maybe different T helper cells go to the table, cytotoxic T cells, you know. So adaptive means it is adapting to the situation. Our assessments related to immune function, nothing crazy here, right? It's all the same things. We're going to ask about infection history, obviously, but we ask about that anyway. We're going to ask about immunizations. We ask about that anyway. So really nothing crazy. I mean, it talks about like asking about autoimmune disorders. Well, guess what? That's medical history. So that is something we cover anyway. So really nothing here is any different than what we already do. We are obviously not doing an activity. Age-related immune changes. We always talk about our age-related things. Just remember that the immune system, as the body ages, the immune system is aging. Okay. So the immune response is it's less efficient. We talked about in the past couple weeks, like if an older person gets an infection, they may not spike a fever, or maybe they get to like, 99.9, and we don't really even consider that a fever. So the body just becomes less efficient at at using those immune responses to help the body. Okay. So this puts our older people at greater risk for infections and autoimmune stuff and risk of cancer and all of those things. Um, because even autoimmune disorders, because the body actually starts to increase production of auto antibodies. Auto meaning self, antibodies. So antibodies that fight the body. Okay. That production increases of auto antibodies. So this puts our older people at greater risk for autoimmune diseases as well. So all sorts of things. Talking about white blood cells. Here's our word differentiated again, okay? When we order a CBC or a complete blood count, we want to order a complete blood count with differential. Differential, again, tells us what those WBCs have turned into, because we have all sorts of different WBCs. We have neutrophils, we have eosinophils, basophils, monocytes, lymphocytes, right? We have all these different white blood cells. And so those white blood cells are basically becoming specialized. All right. So the reason we want to see the breakdown, the differential of the different WBCs is because I want to know which one is most prevalent, because that's going to tell me what my body thinks it's fighting. Okay. So like neutrophils are pretty specific to bacterial infections. So if I look at my CBC with differential, or CBC with diff is how you'll hear it termed, and my neutrophils are elevated, I know that my body thinks it's fighting a bacterial infection, okay? Because my neutrophils are specific to bacterial infections. Now, if I look at my CBC with diff and my eosinophils are elevated, then I'm thinking allergy, okay? Maybe parasite, possibly virus, but really allergy versus parasite, okay? So eosinophils have a different specialization than neutrophils, okay? And then we have basophils. Basophils are what are responsible for a histamine release. Now, think about Benadryl. Benadryl is an antihistamine, okay? Benadryl is against histamine. And what does Benadryl do for us? It stops the itchy, watery eyes. It stops the runny nose. It stops all that extra fluid flowing down the back of our throat, right? It stops the histamine response. So when basophils react, they release histamine, which causes all this fluid to come pouring out, right? What's the body trying to do? It's trying to flush whatever that antigen is. Okay. So a lot of times you're going to see a increase in basophils with an increase in eosinophils, because part of an allergic reaction is that inflammatory response caused by basophils with their histamine release. Okay, so keep that in mind. Know which ones do what. Monocytes. Monocytes are these big old white blood cells. I don't know if any of you are familiar with Pac-Man, but you know how Pac-Man comes along and eats things. Monocytes come along and just eat up damaged cells. They identify antigens. They just kind of clean up garbage. Okay. And then, fun fact, this is a fun fact, but you still do have to know it. You may hear the term bands, BANDS, or a shift to the left. This is when the body is like fighting something and does not have time to differentiate, so throws out baby WBCs, just undifferentiated WBCs. Okay, usually they're neutrophils, they're just not very specialized yet. And this just means that the body is like, I don't even have time to make these guys special. I'm just going to throw them out. They're not going to be as effective, right? They're not grown up yet, but it's something, right? It's something. So these are called bands, or a shift to the left. This comes up again in adult health too. I'm sure it comes up in 8 and 9, and it's one of those NCLEX-y sort of things. So make sure you are aware of that terminology. All right. So this chart is your immunoglobulins. These are your antibodies. Remember, immunoglobulin just means antibodies, okay? It sounds fancy. It's really not. I do want to point out on this table there is a typographical error. It should be IgA, IgD, IgE, okay? E as in eosinophil, IgG, and IgM. Okay, So with IgM, IgM is always the first to the party. So when something's going on, the body's identified an antigen, it doesn't have time yet to make specific antibodies yet. It is going to throw out IgM. IgM is a big old fat antibody. Okay, it gets out there, it swallows antigens, it can take care of them. I always remember that IgM is first to the party because, like, emergency services are first to the party. So emergency M, emergency M, IgM, right? So they are first to the scene, first on scene. Okay. And then so if I run my person's WBCs and I have elevated IgM, I know that the infection is relatively recent, okay? Because IgM is first to the party, first on scene. They're there, right? They're there immediately, okay? So if I have a bunch of IgM, I know this is new. My body's been dealing with this for less than 3 months. And that is our acute versus chronic sort of situation, right? Now, IgG takes a little bit of time. It's a little bit more specific, okay? So if I have IgG elevated, I know my body has been dealing with whatever for a while. Okay, so these are not going to tell us specifically what we're fighting, but they are going to give us a clue to how long the body has been fighting them. So that's why we care about IgM and IgG. And then this one right here, IgE, okay, IgE, that E is for eosinophils. So that again is going to tell me if my IgE is elevated, then I'm thinking allergies or parasite. Okay, so again, all these little things just kind of clue you in to what the body thinks is going on. All right. So this slide is our hypersensitivities. This is the chart out of the book in case you like a chart, but we also have them broken down. So hypersensitivity type 1. This is my IgE. This is my eosinophils. And are you ready for this? I'm going to demonstrate this. I always remember IgE is related to allergies because eosinophils, like you're sneezing, okay? Eosinophils, like you're sneezing from an allergy response, right? So hypersensitivity type 1. This is IgE. This is allergy. Remember, IgE can also be parasites. But we're going to look at hypersensitivities. This is an allergy response. So our first treatment, if I'm allergic to something, remove the allergen, right? If I'm allergic to cats, don't own a cat. Simple. Our treatment going to be antihistamines, decongestants, steroids. Remember, steroids bring that inflammation response down. The body is going to be throwing fluids at this like crazy, thanks to our basophils, right? That histamine. So our eyes are watering, our nose is running. Who even knows? We have phlegm, all the things. So steroids are going to help bring down that inflammation response. Hypersensitivity type 1, allergies can be local or systemic. A systemic allergic response would be anaphylaxis. This means all of a sudden I can't breathe. Local is like I rubbed up against, I don't even know, rubbed up against something and now I'm itchy from where I touched it. Okay. That's local. I can still breathe. It's not really affecting anything else. It's just where I touched it. Now I have a reaction. So that's local or atopic, right? Systemic is when now my whole body is affected. I can't breathe. My vitals are a mess. It's a problem. Okay. So anaphylaxis is the most extreme response to a hypersensitivity type 1. This is where we see shortness of breath, wheezing, crackles. You're going to have maybe skin reactions. even GI stuff like nausea, vomiting, diarrhea. Angioedema, here's a vocabulary word for you. Angioedema, swelling of the lips, tongue, and face. Is this a problem? 100%. Because if this continues to swell, I risk it closing off my airway, right? And that is bad. Okay, that is a problem. Stridor. We talk about stridor because that is when air is having trouble getting through the trachea area, okay, the windpipe. Stridor worries us because that can mean that is closing down. And if that is closing down, again, we're worried about airway. Some other vocabulary for you, urticaria. Urticaria. This is just hives. Okay. Urticaria, hives. One of the weirdo things that you see with anaphylaxis related to vitals is your blood pressure is going to decrease. So remember with blood pressure, what keeps our blood pressure afloat is the fluid in the body. Okay. So I'm having a crazy allergy response. My body is trying to flush out the antigen. So my blood pressure drops because the body is pulling fluid from wherever it can to flush all this stuff out. So you get a decrease in blood pressure. Now, meanwhile, your heart rate and your respiratory rate are going to go up. Heart rate is increasing because it is compensating for the fact that I don't have enough fluid in the body. So the heart knows I need to keep all these organs oxygenated with blood. I need to keep everything moving. So heart rate increases to try to keep all that fluid and blood and oxygenation moving through our organs. Okay. So keep in mind that with your anaphylaxis. All right. Treatment for anaphylaxis. Again, remove the causative agent, right? You have anaphylaxis from a cat, give me the stupid cat. You need to be away from the cat. Again, we're going to use antihistamines, bronchodilators, open up our airways, decongestants, steroids, oxygen, right? Oxygen, of course. Epinephrine opens everything up. It's a fight or flight sort of thing, right? We're going to open everything back up. We may use IV or topical steroids. If my person is having a hard time breathing, I always sit my head of bed up. I don't want my person slumped in bed. I want them sitting up nice and straight. It helps the lungs open up, gives the core some strength, easier to breathe. We also, especially if my person is anaphylaxis, we are worried about losing that airway. So you are going to have that code cart outside that room because we are worried about having to resuscitate this person or place an airway of some sort. Teaching related to severe allergies. So first of all, we talk about the EpiPen. The Epi and EpiPen is epinephrine. It's adrenaline. So that fight or flight, adrenaline, everything opens. Okay. Also, we want our person to consider a medic alert bracelet. Your EpiPen gets carried on you at all times. You don't have to put it in a fridge, anything like that. You carry your EpiPen with you at all times. I love the little thing in the book that says do not share your EpiPen. Like, I'm sorry that you're in anaphylaxis now. Yes, I do have an EpiPen, but I'm not going to help you, right? We're probably sharing our EpiPen in real life, but that's okay. So just keep in mind with your EpiPen, we usually like to do IM, ventrogluteal. If you stand up and you let the tips of your fingers just hang along like your thigh, right? That is essentially where we would give our EpiPen. That's where we instruct patients to give our EpiPen. First of all, it's super easy. You can do it yourself. If you've never seen an EpiPen, it injects when you enter it. Okay, so when it jams into the skin, you don't even have to do anything. It's just going to inject at that point. And it's a bunch of teeny tiny little needles. So even if one of them fails, there's like fail safe. That's what I'm looking for. There's a fail-safe in the fact that there's multiple needles in that EpiPen, so you're not dependent on not bending something or, whatever the case may be. And like in the picture, you can go through clothes. It'll go right through clothes. So we just jam it in. It goes right in that ventrogluteal area. Um, you can, right where your fingertips hit your thigh, that when you're standing, that is basically where we give that thing. All right. Now, the biggest point of teaching is if you utilize your EpiPen, that it's going to work because it's epinephrine. It's going to open everything up. You're going to be okay for a sec. But Epi doesn't last that long. So as that Epi wears off, you are still at risk for that anaphylaxis reaction returning. So you need to seek medical treatment. Um, and that's probably the biggest teaching point with people is you're not out of the woods just because all of a sudden you feel better. You're not out of the woods. So um, you need to seek medical treatment. Um, Also, if you think about the fact that epinephrine is adrenaline, okay, think about after you've been like scared or had something crazy happen and your body's all, adrenalined up, right? Your heart's racing. You can feel kind of like dizzy-ish, maybe nausea, vomiting, you don't feel so great. So we do need to educate patients that this is sort of an expected reaction. I just shot you full of adrenaline. This is an expected reaction. So we don't want them further having anxiety related to those feelings after using an EpiPen. All right, allergy skin testing. So this can be called patch testing, skin testing, anything like that. This is used to determine what specific allergens people are allergic to. So they literally either do a grid, do dots, do whatever. It can be on your arm, it can be on your back, but they inject you with an antigen. Aller- an allergen antigen. How about that? An allergen antigen. They inject you with it and see how you respond. Okay. Are you allergic to it? Do you form urticaria, which is our word for hives? Or do you have no response to it? And if you have no response, that just means you are not allergic to whatever it may be. So they call it a wheal. Okay. A wheal is just like a raised little red bump. You'll hear the term wheal related to TB assessments, skin assessments as well. It's just a raised red bump, okay? But it's WHEAL. So be familiar with that. So we're just looking to what kind of reaction you have to these things. Now, one of the biggest things is if you are going to go have allergy skin testing done, you need to be off of your allergy medications, whether this is stuff like Claritin or, maybe it's a steroid of some sort. You need to be off your allergy medications because if you're on your allergy medications and they're working, then when I go to do skin testing on you, you may not respond. Your body might not respond because you're on medications that are hopefully helping your body not respond. So, um, per ATI in the book kind of differ on this, and that's fine because honestly, it's going to be physician specific, but anywhere from 48 hours to 2 weeks off your medication per provider recommendation. So really it's going to be up to your doctor to tell you how long you should be on these meds. Also, if you have recently had an anaphylactic reaction, we want you canceling your skin test appointment. If you have had an anaphylactic reaction, that means the body is in a state of high alert and not only could overreact with anaphylaxis again to the skin testing, but you are kind of still at risk of your body going into anaphylaxis again, even related to something you maybe don't even normally respond to, simply because your body is all worked up still from this anaphylactic reactions. You have all this histamine probably still, you have all these antibodies floating around still, and the body could potentially overreact again. So anaphylaxis, contraindicated for skin testing if it's been a recent anaphylaxis. DC your antihistamine and steroid treatments 48 hours to 2 weeks beforehand per provider recommendation. Here's our hypersensitivity type 2. We care about type 2 because this encompasses blood transfusion reactions, okay? This is blood transfusion reactions. So what our book says about blood transfusion reactions, and you can see there on the chart, like there's different types of blood transfusion reactions based on different antigens. All right, we don't care about that yet. All I care about is if I am starting a transfusion and my person has some sort of a weirdo reaction of any sort, whether it's an increase in temp, whether it's the fact that they're like, you know what, I just don't feel so good, right? Because when patients say that, we believe them. Whatever the case may be, our book says stop the transfusion, okay? Stop the transfusion. Do not leave your patient unattended, but we want to notify the physician. So this may be calling a rapid response. Like a rapid response gets people to your bedside to help you, because I don't want to leave this person by themselves. If they go into an anaphylactic reaction, I need to be immediately at that bedside. I don't have time, right? I don't have time to run back into that room. I need to stay at that bedside so that if something bad like anaphylaxis goes down, I am right there to start treatment. So don't leave your person unattended, but do notify the physician. This may be somebody else, likely somebody else, notifying the physician for you. Signs and symptoms of hypersensitivity to blood transfusion: chills, fever, pain, heat sensation, like they may feel flushed, right? This could be heat at the infusion site. Worst case scenario, respiratory distress. Okay, your safety alert box is on page 391. And then there's different reaction types on 179. But again, you don't have to memorize those different reaction types. You just need to know that we stop that transfusion, do not leave your person alone, and notify that physician. Hypersensitivity type 3. So these are kind of weirdo. Don't spend a whole lot of time on this. Hypersensitivity type 3. These can be related to autoimmune things. So what happens is the immune system has a reaction to a med, or like an anti-serum, which is, and a lot of these things are proteins, okay? And so like tuberculin's a protein. That's what we use for like skin testing with TB. It's a protein. And so sometimes you are having a reaction to the protein and not actually like having a positive TB reaction, for instance. Okay. Also like penicillin. Penicillin is a huge reaction point for people. This is hypersensitivity type 3. Okay. The weirdo thing I will tell you about hypersensitivity type 3s is that they can have delayed reaction. So it can be up to 3 weeks post exposure that you have this reaction. So the crazy part about that, I mean, 3 weeks later, I can't remember yesterday sometimes, right? Like 3 weeks later, you're going to be like, what the heck is happening here? So just keep that in mind with hypersensitivities type 3. It can be a very delayed reaction. Okay. These hypersensitivity type 4, this is like your poison ivy, right? This is your poison ivy. And also the TB test, the skin TB test falls under type 4 because it's a delayed reaction. Poison ivy, like I have no personal experience with poison ivy, but apparently, you rub up against the plant and then it takes a while actually for those blisters to appear. So it's just a delayed reaction. The skin test for TB, I inject you with the tuberculin, the protein, the synthetic protein, and then I don't read that, I don't look at it until 48 to 72 hours later. And that's just a delayed response. Okay. So hypersensitivity type 4, delayed response to whatever that antigen is. Hypersensitivity type 5, nobody cares. This is Graves' disease. Unless you are, for whatever reason, specializing with patients with stuff like Graves' disease, you don't care about this. Okay. All right. Skipping some think like a nurses. Skipping some things here. All right. So slide 22. This is talking about HIV and AIDS. Now, this slide has a whole bunch of information on it. What you really need to take away is that there is a whole long process that where HIV actually becomes AIDS. Okay. Just because somebody has HIV, is HIV positive, does not mean they have AIDS. AIDS is the last end cycle where the immune system is no longer existent, and AIDS is the very last your person's going to die related to having been infected with the virus. So when you get infected with HIV attacks the T cells. Okay. Now, as we learned on like slide number 2, the T cells are imperative to our immune system. So HIV gets in there and starts attacking those T cells. And so what you see with people with HIV that go undiagnosed and untreated is their T cell count just gets depleted, okay, to the point that their body no longer has any immunity. They can't fight off anything. That is how low that CD4 or T cell count gets, okay? Now, HIV can be present in the body for about 10 years before somebody becomes symptomatic. By the time somebody becomes symptomatic, that indicates that those CD4 cells or T cells are so low that the body is no longer fighting off things. Once somebody reaches that point, then it's about 2 years before they will develop full-blown AIDS and expire. This is when your CD4s are less than 200. CD4s less than 200, you have no immunity left. Like your body can't fight anything. So what actually ends up killing people related to AIDS is opportunistic infections. I'm going to switch slides here real quick. Here, this is slide 24. I'll go back to 23, but these are the opportunistic infections that we see with AIDS. So it's still not it's not literally the virus that kills you. It's the fact that you now get these weirdo infections that otherwise healthy people are not going to get. So one of the things we see is this pneumocystis jirovecii or pneumocystis carinii. They actually changed the name on it. We still call it PCP. Okay. We still call it PCP. It is this weirdo fungal pneumonia. Okay. It is specific to AIDS patients because otherwise healthy people, even immunocompromised people, do not get PCP. Okay. The problem, so let's back up a second also. So as the body progresses to AIDS, we see what's called cachexia, and this is muscle wasting. So this is not just like your person is losing weight. This is them losing muscle. And these people, if you have never seen pictures of patients with AIDS, it literally looks like their skin is just hanging off of them. I mean, it's so sad because there is no muscle tone anymore to support the skin. So their skin just hangs off of them. They just look depleted and sick. They look sickly. Cancer patients can, especially towards end of life, can look similar. Okay. So back to pneumocystis jirovecii, this weirdo fungal pneumonia. The problem with this pneumonia is that it creates a really thick, like our word for thick is viscous, okay, viscous sputum or phlegm. And the problem is your person is so depleted and has no muscle and no strength that they cannot clear this phlegm from their airway, this sputum. So they may, like, they can't cough it out, is basically what it comes down to. They don't have the strength. So we worry about the airway with this. Essentially, them choking and dying on the sputum because they can't clear it. We are going to identify PCP by culture, right? We're going to do a sputum culture, run it, see what we have growing. An x-ray would be helpful just to identify pneumonia. An x-ray is going to show us that we have fluid in the lungs, which indicates a pneumonia. It is not going to specifically tell us PCP. Like, we need to run a culture to find out what our organism is. All right. Um, Another opportunistic infection is thrush. Thrush is a yeast infection of the mouth. You will see this like a white coating on the tongue, on the mucous membranes. You know, it's thick, you can scrape it, but thrush is considered an opportunistic infection. Also, we worry about a change in mental status with our AIDS patients because they can get opportunistic infections in the CNS that like travel to the brain. Maybe they become a tumor, something like that. And so any change in mental status, we worry about. We worry about severe headaches. We worry about visual changes. um, the book talks about unexplained weight loss, and this is kind of like a difficult concept related to AIDS patients because they're going to have weight loss anyway. But what the book says about this is unexplained weight loss is a weight loss of greater than 10% from the last weight taken. Okay, so if somebody has greater than 10% from the last weight taken and there's no other reason, we consider that unexplained weight loss. And so we would worry about that. Also, keep in mind our AIDS people have no immune system. So they are just going to be living with low grade fever, probably going to have a cough. They're going to be exhausted, extreme fatigue, cachexia, which is that muscle wasting, loss of muscles. Also, lymph nodes are going to be swollen, right? The body is trying to do whatever it can to fight off infection. So those lymph nodes, they're going to be working overtime trying to filter things for us. Not going to be very effective, but they're going to be swollen from trying. One of the other opportunistic infections we worry about is called Kaposi's sarcoma. This is actually herpes virus 8, okay? It is cancerous. The problem with Kaposi's sarcoma is these form cancerous lesions anywhere in the GI tract. So from the mouth to all the way down to the anus, all the way down to the rectum, through the rectum, you can have these cancerous lesions. they can be huge. They're they're huge. So think about this. Can your person eat? You have cancerous lesions lining your GI tract. Can you eat? You're not eating, right? You feel horrible. You also probably can't keep anything down even if you could eat. So Kaposi sarcoma, horrible, horrible, horrible. There's a picture on let's see, slide 26. Here you go. Here is Kaposi sarcoma on the skin. So these are cancerous lesions. And like these ones are actually like really not that large compared to some of the stuff I've seen. They can get like I don't like the size of a baseball. I mean, it's crazy. So there's your Kaposi sarcoma. And again, that's considered a opportunistic infection. My slides won't let me go backwards, so I'm going to restart for 1 sec. Okay, my slides won't let me go backwards without undoing all the recording that I've done. So we're going to talk about a little bit. We're going to sit on slide 27 and just finish talking about HIV. So the other opportunistic infection that you need to know about is tuberculosis. Tuberculosis in immunocompromised people, especially AIDS patients, is considered an opportunistic infection. And again, that is because, first of all, we don't have outbreaks of TB. TB is not, I should say, TB is not endemic to the United States, right? We don't expect people to have TB. You know, a while ago, a few years ago, there was an outbreak of TB among homeless in San Francisco. TB, you can get outbreaks in prisons because people are living in such close confines. And then you have people out of the country who bring TB in, and then that population is at risk. But for the most part, we don't deal with tuberculosis on any large scale in the US. So, tuberculosis is another opportunistic infection related to AIDS patients. Now, if we go back to the slide that says like HIV treatment, so the one before the opportunistic infections, it has like a butterfly on it, the ribbon with the butterfly. Our treatments for HIV these days is called ART. So antiretroviral therapy. There you go. ART. So the thing with ART is it consists of multiple pills. And you have to take these meds at the same time every single day for the rest of your life for them to be effective, period. So this can be challenging. Our biggest problem is going to be compliance, right? Especially if we are talking younger people, where they just don't feel the urgency related to this. You know, back in the 80s, people died from HIV. Like it was a death sentence. No questions asked. If you were diagnosed with HIV, it was a death sentence. You were going to die from AIDS. These days, that is not the case. And so compliance, I mean, not just related to like art therapy, but there's even like what they call PrEP, which is like prophylactic um, treatment for like if you are in one of the higher risk populations, you know, men on men, if you don't practice safe sex, if you have multiple partners, maybe you're a sex industry worker, you know, stuff like that. Anything that puts you at an increased risk, there's PrEP for now, and it's capital P, small r, EP, and it's just for like pre-exposure. So there's all sorts of options these days, and HIV is no longer a death sentence at all. You know, it just isn't. So people have a much more, especially younger people who don't remember the 80s, have a much more casual attitude towards treatment and safety and exposure. So when we get to talking about art therapy, where you have to take it same time every day, rest of your life, That's hard for people to do. So some of the education points that we talk about related to art are like if you feed your cat at 5 o'clock every day, right? So you feed your cat 5 o'clock every day, make that also when you take your meds, or you wake up at 4 o'clock every morning and go for a run. So make that when you take your prep. Tie, or not your prep, your art. Tie your treatment to something that you already do so that you don't forget. Okay. Um, so that's pretty much it related to art therapy and prep and all of that. I'm gonna pause this one sec. I want to go look at the other slide. One sec. Okay, the other slide that I didn't get to talk about was just kind of a refresher on neutropenic precautions. So this is for people with less than 1% WBCs, right? And just remember that neutropenic precaution protects the patient from us. So when we wear N95s and put people in negative isolation, negative pressure isolation, that is because we don't want whatever the patient has to get out into the hallway to other patients, to us, right? Negative pressure keeps the germs in the room. All right. So positive pressure is what we use for our neutropenic patients. They have too little white blood cells, neutropenia, too little white blood cells, less than 1%. They can't fight infection. So neutropenic isolation protects the patient from anything that may float into that room. Okay. Also, remember, we're wearing gowns, masks, all that stuff. Plus, we don't want our person to have fresh flowers. There's organisms on fresh flowers. There's organisms on raw vegetables and fruit. So we kind of discourage that. So that's really, just take a look at that slide for neutropenic precautions. I know you guys learned about it in funds, so just kind of do a little refresher on that. All right, HIV case study. All right, moving on to MRSA now. This is slide 30. So MRSA, methicillin-resistant Staph aureus. Okay, we can have good old-fashioned Staph aureus that is not resistant to methicillin. This is not usually the case. MRSA is so prevalent these days, pretty much upwards of 90% of staff test resistant to methicillin. Just as kind of a fun fact, because of that, like so much staff is methicillin resistant. In real life, in the lab, we don't even test it against methicillin anymore. We test it against oxacillin. So in infection control land and lab land, it's really ORSA these days, but they felt like MRSA was such a part of the like American lexicon. Like everybody knows what MRSA is, right? So they decided not to change the acronym to ORSA. So just a little fun infection control stuff for you there. So the super simple story related to MRSA is that it developed resistance related to overuse of antibiotics. Not a shocker that it's a little bit more complicated than that, but base level, MRSA is related to overuse of antibiotics. Okay, that's what we're going with. The thing with MRSA transmission is direct contact. So that's why our people with MRSA are going to be in contact isolation, gowns and gloves, right? Because if I touch this and then I touch that, I can transmit MRSA. All right. Keep in mind, like our MRSA patients, our isolation patients can have visitors. We just, for the most part, most facilities are going to have the visitors adhere to contact isolation precautions and hand hygiene. So with MRSA, we just have to gel in, gel out. We want our visitors to gel in, gel out. most facilities are going to expect their visitors to wear a gown and gloves. And there we go. Now, if we are talking like rehabs and SNFs and, maybe care homes of some sort, you can have people there, patients there that may be MRSA positive, right? So the biggest thing is to reduce potential spread. Like, we don't want patients sharing things. I mean, this is true for acute care facilities as well. It just doesn't happen as much. Like, there's not as much potential for patients to share things. So, but just think like, we don't want them sharing towels. We don't want them sharing linens. We certainly don't want them sharing like toothbrushes, right? We want patients to have all their own things. And this is just going to help cut down on that contact transmission. This is hospital-acquired MRSA versus community-acquired, associated, whatever, MRSA. They are different molecular structures, and therefore they present differently. Honestly, hospital-associated MRSA, a little bit less virulent and nasty than community-associated. Community-associated is kind of what we associate with that flesh-eating bacteria, right? That's community-acquired MRSA. Hospital-associated or hospital-acquired MRSA, it's still a skin infection, a tissue infection a lot of times, but it's not skin, it's not necrotizing. Okay, it's not eating skin. It's just making healing difficult should it get into a wound. So soft tissue, pretty common. But you know, you can see it other places, but soft tissue most prevalent, okay? But you can see the difference if you look at these pictures. Like, look at the surgical site infection, surgical site MRSA infection. Look at those wounds. Like, they're not great, but look at the community associated MRSA. Look at that. That is a mess. They are going to have to debride that off the top before anything can heal. All that yellow around there is pus. All you peel that, you debride that off the top, that is going to be pus underneath. That is disgusting. And then look at all that inflammation. Look at those fingers. Like, that is a mess. Like the surgical site infection with the hospital associated MRSA, it's not wonderful. It's dehiscing. My site is pulling apart, but it's nothing like the community associated. All right, C. diff, my favorite. Here we go. It's a spore, okay? It is a spore. And are you ready for transmission? Fecal to oral, poop to mouth, fecal to oral. You are transmitting spores from the poop into your mouth where you swallow them, and then they go into your gut and they cause C. diff again. Okay. So that's disgusting. I feel like that should be enough of an education for people to buy into hand hygiene, right? Because that's gross. So our treatment, we're going to do PO Vanco. All right. We're going to do PO Vanco. So oral vancomycin. Problem with vancomycin is it's very nephrotoxic. So before we give Vanco, we check our BUN and creatinine, okay, which tells us how our kidneys are doing. We also need to run a trough on Vanco to get it to therapeutic serum levels. So when you have a patient on Vanco, like, you're going to have a trough ordered, like right when you start, and then maybe every 72 hours. And basically that's just to see where that Vanco serum level is and whether you have reached therapeutic levels. And if it's higher or lower, then your Vanco dosing will be adjusted by your physician. Sometimes depending upon hospital policy, but sometimes the pharmacy will adjust dosing. So don't forget with C. diff, our greatest risk factor to acquiring C. diff is antibiotic use. And this is because antibiotics are great for killing off bacteria, but they don't differentiate between the good bacteria versus the bad bacteria. And part of the thing that keeps our gut healthy is good flora, which includes good bacteria. So when we are on extended antibiotic use in particular, um, all of our bad bacteria may die. Okay, good, that's great. But all of our good bacteria gets killed also. This good bacteria is what keeps a lot of these opportunistic infections at bay. So if we kill it off, we do not have any ability to fight off these infections. All right. So our person's on antibiotics. We've killed off the good bacteria. Guess what else we like always put patients on in the hospital? PPIs, proton pump inhibitors. Proton pump inhibitors stop the gut from producing acid. On top of the good flora in the gut, guess what else helps kill bacteria? The acid. Okay. So now we've killed all the good bacteria. We've stopped producing acid. C. diff gets into that gut and is like, this is great, thank you, and is able to proliferate because we've killed off all of our defense mechanisms. Okay, so antibiotic use, number one cause of C. diff, period. But PPIs, very, very, very close second, very close second. All right. And again, that is because we've killed off our defense mechanisms. Your person that has C. diff is going to be on enteric contact isolation. Enteric just refers to gut bugs. This clues us in to the fact that we need to wash our hands with soap and water on the way out of that room. And we need to wash with warm soap and water for at least 20 seconds. Okay. And this is on the way out of the room. You can gel in. Okay. You can gel in. That's totally fine. But on our way out, we need to wash with that soap and water. And is the soap and water killing the C. diff? No, it's just washing it down the drain, just washing it into the sewer system, just sending those spores on a nice little trip, right? We're not killing anything. Really, the only thing that kills C. diff for the most part is bleach. There's some other sporicidals out there that may kill your C. diff spores, but we don't want to use them on our skin, right? We don't want to kill our skin. So keep in mind when we are, if we have a C. diff patient, we want to be wiping down our workstations with our bleach wipes, our Sani wipes, if they are sporicidal towards C. diff, and making sure if you look on your wipes, it gives you a kill time or a dwell time, and that is how long a surface needs to stay damp with the bleach or the sporicide to actually kill the spore. So, like with bleach, I want to say it's 2 minutes. I am not positive, but that means that your surface, your workstation needs to stay damp with bleach for 2 minutes to adequately kill that spore. Okay. And honestly, 2 minutes in nurse time feels like forever. Like that feels like a ridiculous amount of time. So, but keep all that in mind. All right. We have some think like a nurse.